Good evening and welcome to AMDA COVID Grand Rounds, Pearls from your colleagues. I'm Sabine von Price with the Washington State AMDA chapter, your host. This is part of an ongoing peer discussion on COVID-19 in the post-acute and long-term care space. We know our patients and our care teams have some very specific needs, and we want to make sure that we learn what we can about what serves them best through data insofar as data are available or best practices. This is an interactive discussion and we invite you to use the chat function to engage with us with questions and contribute your insights as well. We are always keeping an active look at the chat function. When COVID-19 hit our facilities seemingly out of nowhere in March, we were all scrambling to, as Dr. Ney said, build an airplane as it was taking off the runway. Now we are over 4 months into the pandemic. It seems like eons. And now there is no end in sight. Cases are reaching new heights in our country, and we are looking towards the fall and winter with flu season ahead. Today we want to discuss 3 important areas. What do we know about keeping our patients safe? What have we learned? And how will it help us moving forward? What are our gaps in knowledge and how will we bridge those? And finally, and I'm looking really forward to that one, what are we most worried about? What keeps us up at night? And what approaches are our colleagues taking? If you have any other questions that are burning to you, feel free to raise them. I am sure we can all learn from them. To discuss these important questions, we are very pleased to have 3 distinguished colleagues join us today. We welcome back Dr. Chuck Griselius, one of our past AMDA presidents. He is a practicing geriatrician and director of the Post-Acute Care Services for the BJC Medical Group ACO. He's a multi-facility medical director for Delmar Gardens Enterprises. And among his many professional endeavors, he is also the project medical director for the CMMI-funded Missouri Quality Initiatives for Nursing Homes, which is studying ways to decrease unnecessary hospitalizations. For the first time today with us is Dr. Nancy Istenitz. She's a geriatrician and medical director who serves on AMDA's Public Policy Committee and on the board of the Ohio chapter of AMDA. She always has had a passion for nursing home residents and has spent a large part of her career working in skilled nursing facilities and long-term care settings. Currently, she is the Chief Medical Officer for Saber Health Healthcare Group. And last but not least, Dr. Susan Levy. She really needs no introduction. As a past president of AMDA, she has guided the organization and continues to advise us and contribute to the care of our most vulnerable elders. Currently, she is the medical director for 2 nursing homes in Sussex County, Delaware, and continues to serve AMDA as vice president of the AMDA Foundation Board. Let's kick the whole thing off with a poll. Poll number 1, please, Erin. What COVID intervention do you feel has been most successful in preventing ongoing COVID infections? And I'm reading them because some of you may not seeing them. Facility lockdown, no visitors. Staff wearing PPE, including face masks and face shields. Government orders, including shelter in place and mandatory face masks. Dedicated COVID-19 units, serial testing, or all of the above. Go ahead and vote. And Erin, we give this usually about a minute, and we can't see the voting, so I appreciate if you share it with all of us. All of the above, that's not a surprising result really, but it's interesting when you look at this. Facility lockdown had some, but staff wearing PPE seems to be the winner here. and then very little really for government orders, including shelter in place and mandatory face masks. That's interesting to me because I have felt that I greatly relied on that. And then, of course, all of the above. But serial testing in and of itself does not win. Let's start with you, Dr. Levy. What are the most important lessons you have learned from COVID, from the interventions, and what do you think you will carry forward?
Well, certainly a lot. I mean, there's a whole bunch of things. I'll try to focus on maybe one that we maybe haven't thought about, but planning, preparation, communication, coordination. I mean, I was on a call with, I'm in a small state, one of the smallest states, with their, person who's been contracted with to do a debrief and, give feedback to the local health department in the state. And I think my list went on for 3 pages of all the things that I felt that we needed to, address. Part of just debrief, but also in terms of planning for resurgence. Without the basics, you can't make this happen. And that the basic principles of infection control actually do work. And I think we all believe in that. We know that, that the science does work. It's cumbersome, it's difficult, but I think that's critical. And we've got to keep our eye on that. But one of the things that particularly I was trying to get a message across to folks in our state is that this was not all about the hospitals. And I think one of the mistakes we made, our hospitals never really surged. They had a lot of admissions, a lot of critical care admissions, but they never really hit surge capacity. And yet many of our nursing homes were actually devastated. Our state mortality rate's one of the highest at 65% of our deaths are related to nursing home residents. And so I think that in retrospect, if we had thought about infection control, it would have been about prevention. And we should have known where the hot spots would be and focused our efforts there. We should not have been in second tier for testing. We should have not been told that once you've had 2 cases, you don't need to test anymore. There were so many mistakes made because of some of the limitations we had, but really needing to advocate for the fact that nursing homes must be included in all these plans. And frankly, medical directors need to be at the table with this because we bring a unique set of skills and knowledge. So sorry I went on for a bit, but those are a few things that I think I've learned and want to carry forward.
I think this is very interesting to me because, as you may or may not know, Washington was one of the first states hit. My nursing home was the second nursing home in the country, and it did lead to a surge in the hospitals. And there was a lot of energy spent around that. And nursing homes were the second tier. And although we had a substantial amount of deaths in nursing homes, but it was all about the surge capacity in the hospital. And you're right, that was wrong. Dr. Istides, what is your perspective on this?
I agree with absolutely everything that's said so far. I think one of the things that still sickens me is that concept that once you have 2 cases, they're all positive. I can't tell you the number of local health departments I had to fight with for my buildings to say no, because they would tell us to stop cohorting residents.
Really?
So I'm a big proponent that you need to cohort your positives and to the best that you can put some sort of barrier up. And it's not that a barrier between your positives and your kind of what I call a naive population really helps with that aerosolized spread. But it is a really strong reminder. So in a lot of buildings, like we put up the plastic walls with the zippered doors, and we did have negative airflow pressure that went into some of those units. I'm not sure that the negative air pressure did a lot. What I think really helped was that plastic with the bright red zipper was just enough that, even though you have dedicated staff for the COVID positive unit, it kept other staff from accidentally walking onto the unit and carrying something in or out or bringing supplies. It made everybody stop and think. And as soon as we erected those, got our positives behind those units, things really settled down in the building. So where we had buildings that their populations, early on, we had a few buildings that were full and we couldn't cohort very easily. We couldn't get the testing to figure out who, the exposed roommate, where did we put them? If we can get quicker testing. I would say that with that testing component, we weren't second tier. I think we were probably at least third tier, because how many drive-up testing centers
Good point.
opening in our communities before the nursing homes got testing?
Mm-hmm.
So I think we were third or fourth tier, for getting that. And I do think that the government orders, I'm with you, Sabine, helps. I think that the more things are kind of locked down in the communities, I think the mandatory masking really helps in the community to keep our workforces healthy, so they're not bringing something in. And with so much asymptomatic disease, that's really important. And we have PPE and they wear it and they do all the infection prevention and control. But when you think of all the touch points of care that we give in a given day in a 100-bed nursing home, it's just human nature that there's going to be some breaches. And so if we can keep our workforce safe and clean or healthy, that really goes a long way. To be able
I couldn't agree more. And actually, jumping way ahead in our discussion, that is what keeps me actually up at night, not being able to keep that workforce
you look at the statistics
healthy.
that minority populations, low socioeconomic populations are harder hit by this. That's our workforce.
Yeah, and they're living in more crowded conditions.
In a way, we get the double whammy.
Or the younger people who think they can party. I mean, they scare me a lot, actually. But yeah, I think that COVID unit, that plastic fence, that construction fence, I think that was a brilliant new apparition in nursing homes, and it's really, I think, done a lot. And I couldn't agree more. And you described it beautifully what it does.
We have really pushed like team nursing and helping your colleagues and crossing to the other unit to help them out. And that's been what we've done because of the staffing crises. And it is really hard to break that. And that wall helped to break that thought process so that we could really isolate those residents.
Dr. Crecelius, what say you? What is a takeaway? What have you learned that you didn't know before?
Yeah, 2 points. One is you've got to get your face in front of your Department of Health in your state and just be annoying. They don't listen at first. They think they know everything. They don't about our site of service. They didn't put us in the right priority line. Then you have to just keep knocking the door, no matter how annoying you are. The second one, I emphasize, I think it's really the staff. I mean, I'm convinced the staff are the only ones that bring in the building. It's not the hospital transfers. That's a rare event. So really talking to your staff about what they have to do. We've been using a lot of the sports team analogy. When they build sports team, I work with the Blues. Mm-hmm. You get 4 people together, that's a pod. You work together for 2 weeks. Then you add another 4 players. We advise the same thing to our workers. Define your family as no more than 5 to 6 people at the max. You isolate yourself. 2 weeks later, you get another group in, and you can build a larger unit, but you have to all pay attention to the rules. The sports team analogy, I think, hit home with a lot of them, but that's how you can start building up a small community that's safe. They're going to go out and party some. They're going to do wrong things, but if they do it with social consciousness, it's possible to do. I'm seeing my grandchildren because we followed that procedure. I'm so happy I can see my grandchildren because I know they were responsible. My kids were responsible. Mm-hmm. But the idea of building a team that applies not only in the home, but a family. It's really important to engage the workers in this and make them feel like you're really listening to their needs.
Well, thank you for that perspective. I think really getting in front of it, this is something that was completely new for me as well. Getting in front of the government, the legislature, the governor, and the COVID response team that had no medical director on it, tons of hospitalists, and they got all the attention, and really being. I learned how to be annoying, and maybe I knew that pretty well before, but I think you have to have the courage to be annoying and really knock on those doors and say, hey, our patients need interventions to keep them safe. So, well, yeah, so I think there's a lot of things that we have learned, and I think we'll be the better for it. What do you think we're going to keep also possibly moving forward with flu season, Dr. Levy?
I'm sorry, what are we going to?
What are we going to keep of those things that we have learned, and what are we going to apply to flu season potentially?
Well, what I would like to say is, back to the old plan and prepare, which, we're hitting. I've always said in August, there should be, even in nursing home chains, there should be flu prep sessions. Hospitals do that. Healthcare systems do that to really make sure that, they've got the right information coming in, that they're sure they're going to have the adequate supplies, and then begin that planning process. But I think testing is going to be, one of the key things. And then again, the whole question about what types of testing to be doing in nursing homes and have rapid access to be able to know once those symptoms develop, once we identify, because it's going to happen. There's going to be there isn't almost every building every year, there's some type of respiratory outbreak, whether it's, flu or a mild coronavirus, something that happens. So I think that's going to be critical. Hopefully, better coordination then with the health department. One of the things I found interesting is during flu seasons, the health departments may ban admissions or tell you that, you've had too many, cases, you really shouldn't be taking on admissions on that unit when you call in and give them your updates, or suggest that. And the irony was, again, because such of the focus was on the fear that the hospitals were going to get overwhelmed, I think there was only one facility. We had several fairly nasty outbreaks. One facility in our state that actually, where admissions were actually officially banned. And to me, now the facilities themselves stopped taking admissions because they were, in many cases, overwhelmed. But, to me, it was kind of like, this needs to be a partnership. You need to also be able to tell facilities, you know what, you've got enough on your hands right now. You're really on the borderline. The last thing you should be doing is taking no admissions. And that gets in the whole issue about alternative care sites. And I know that's another, political issue, but those were being set up for hospitals. Many of those were not needed by the hospitals. And yet we really had no alternative care sites to be able to send patients to.
Yeah, so that needs to be possibly something that needs to be reviewed. Hey, I'm keeping those construction fences. And I've had isolation for flu, but I have usually not cohorted, or very little cohorting took place. But hey, why not? I'm planning to use them if I need to. Dr. Istinis, any comments on flu season and what you would like to see, and what you learned?
Yeah, I think that moving forward, whether you start looking at flu outbreaks, norovirus outbreaks, any sort of infectious disease, our approach to it is going to be different after this. But I think we do have to have some discussion. This may not be the time to open it up now, but what is the best, do we cohort flu? Do we cohort flu with COVID? Do we cohort it separate than COVID? We already have a building that right now, most, depending on your status, can have 3 distinct areas or zones. COVID positive, your new admissions, exposed observation, whatever you want to call that. And then your COVID naive, your red, yellow, green. Every state has a different moniker for all of that. Now, if you start taking and saying, okay, we've got our COVID positive unit and we have our influenza unit and we have, the buildings are not going to be able to do it. They're not going to have staffing for that many different populations. So we have to figure out how we do that, and we do that well. But I think if cohorting was a big way to help cut down these outbreaks, it's probably going to work some for flu too. But how do we do those together if we need to?
We'll have to see how bad COVID is going to be, right? Dr. Priscilius, any thoughts on influenza and when it's going to hit us and what we should be doing?
I'm going to be somewhat the blind optimist and assume that all the isolation we're doing for COVID will really benefit the flu season.
Yes, I'm thinking that.
The real question is going to be, in my mind, are the staff going to be more willing to get a flu shot that COVID did and passed? Will owners be willing to mandate flu shots, given what they've experienced? The PR alone, going to a building that doesn't mandate flu shots. Are you kidding me? We just got through COVID. You're not mandating flu shots for your workers. There's going to be some real pressure.
Mhm.
And so it's going to be us at AMDA also. It's upon us also to kind of push that agenda forward. And this will be another like knock knock on the government's door and saying, hey, we need to push that agenda right now.
Yeah, we've already had some internal discussions in our ACO, our preferred partners. Why are we using any nurse home that doesn't make the workers get flu vaccine?
Mm-hmm. Now you're going to change your mindset.
Yeah, when it comes to a business of all money, all of a sudden minds change.
Yes, that's the way to change it. I got it. Once the ACOs say you need to have flu vaccine mandatory, that may actually be the way to change it.
Oh, wait, well, thank you. You know, the provision of any assistance from any managed care product is going to be pushing us.
Yep, I think that's not a bad idea at all. Okay, let's go for the second poll. Touching on some areas that we are not so sure about, maybe. At this point, what strategy are you using in your facilities to discontinue transmission-based precautions? Test-based to negative, time-based, combination-based on individual case? Or are you not involved in the decision to change precautions? All right, interesting. So fairly clear that time-based precautions are favored by the majority, with only 20% test-based, which is something that I'm insisting on, full disclosure, and then a combination. So the question then is, and some of us are not involved, okay, fair. If you're not a medical director, that's fair. If you are a medical director, you definitely need to be involved in that decision. So what do you guys favor and what's the science behind it? And it also reaches into the next question, which is who should be advising us on that? Who should it be? CDC? Should it be CMS? Should it be the local? We getting stuff at us from every which way, and we have CDC changing their minds. So ideally, we'd look at some evidence. So anybody want to take a stab at that? What they're deciding and what the evidence is for that?
Yeah. Yeah, I'll take a first stab. I'm a big believer in time-based, and we reinforce that today. Our local capacity for testing is horrible. We're up to 8-day turnaround time.
Oh yeah, well.
That's one of the issues, and it becomes irrelevant.
Right.
The state epidemiologists, the latest evidence is that for 14 days, only about 1% of people may be infectious, and we just can't afford at this time to run those tests. I think it should depend on science. If your community prevalence is low, it makes more sense. If the reproductive rate is low in your community, it makes more sense to trust time-based. I have to admit, if the R is really high and your community rate is off the wall, yeah, maybe test-based makes more sense.
Why is that?
Well, first of all, you've got pre and post-test probability factors going into it.
Oh, that's true, yeah.
That's part of the equation. A false positive is much lower when the prevalence is low. False negatives may change though. And some of it's just pragmatic and test capabilities at this time. If we get down to spot testing on the spot and widely available, then that may happen. I received bad news today from our supply chain people know that some of the rapid testing is going away. Some of the companies making it may pull off the market.
Okay.
Uh,
Well, where are you located, Dr. Crecelius, again?
St. Louis, Missouri. Yeah,
In
we're
Missouri.
yeah,
Okay.
sort of a medium activity area.
Okay.
Yeah, and
I'm just shocked that it takes you still 8 days to get a test back.
that just happened recently because of Florida, Texas, Arizona.
Yeah, they all went,
Okay.
everything went there.
Everything went south. So
First,
I'm
we're
a big believer in CDC setting guidance. You know, they should be able to say it's community based. You do this.
Right.
But it doesn't make sense to me that you're kicking the can down the road where there's a lack of science. They say, well, let your state decide. And the state feels the science is running short, they let the local department decide.
Right.
And that's, it has nothing to do with what's right and wrong. It has to do with who wants to be stuck holding the bag of bad decisions based on a lack of science. So they just kick it downstream.
Mm-hmm.
Editorial comment.
It also almost seems like what is, and I think that's something that you just demonstrate, or you just, I just heard you say is what's available is what we're going to do. Well, that's certainly a must-needs approach. Dr. Istenes, how do you deal with that?
so we've been doing time-based, and we started off with kind of test-based and pushing toward that, and I just found it absolutely impossible.
Mm-hmm.
People continue to test positive for 6 to 8 weeks. We know they're not infectious out that far. We have residents that are further isolated on our isolation units, and we're not able to kind of get them off. Because of risk for aerosolization, we were doing bed baths on our COVID positive residents. So, I mean, those patients need to get a bath. I mean, they want to get a shower and to be practical. So early on, the state of Ohio had said 14 days rather than the 10 days that the CDC was saying. We decided as a company, well, we'd be a little more cautious. So we're doing the 14 days with 3 days symptom-free. Because we just find that the test, and we're even having some issues now where we've had somebody who's been, almost 6 weeks since they're COVID positive, they were COVID positive. We know they're not infectious anymore, but they had to go to the hospital for a procedure. They insisted on testing them, and lo and behold, it's positive. And we really feel that that is just, RNA fragments somewhere that they're picking up.
Right.
So I've been pretty adamant that the buildings need to go with time-based just to keep things moving from that aspect. And we have not, seen where we feel that anybody has spread it after.
Okay, so that's what was my next question. What's your results with that? And it'd be interesting to publish that somewhere because I don't think we've seen evidence really. I feel like the CDC is doable
now, but to the best of my knowledge, I haven't had an outbreak that I've tied back to a resident that we removed from transmission precautions. I've, really said to our staff, that 3 days symptom-free, I do not want you skimping on that. If that means that they are 16 days or 20 days, if they're still having symptoms, although sometimes then if they are having symptoms out that late, I want to remind them to look for secondary issues, that secondary bacterial pneumonia, that's something else that's causing that symptom that's not COVID. We don't want to be blind to that either.
Okay.
Yeah, I would agree. We were a little different in two different facilities, but the facility that got hit the hardest, we were very slow in graduating people, but chose to go with, actually some of the docs from public health got me convinced that, that the test-based made more sense. And I think very much for what Nancy brought up, and we've had a couple of these cases. And the problem is it creates implications. If you now have a patient you've graduated, you feel is recovered, they're off precautions, and now your building is essentially recovered. And so in our case, if you have a positive case in the building, everyone's in gowns and gloves. So that we had someone who was tested in the building, not really clear why somebody did that test, but it got done. It came back positive. The person had no symptoms. But, based on discussion with the health department, we had to go back to basically be a COVID facility with one case and had to, redo everything and go through that for 10 days. For that, we just did 10 days because we felt the patient was asymptomatic. And then there was a similar case of a patient who had recovered, gone out to the hospital, quite some time later, not clear why they did a test. And again, it may have been because they were going for a procedure. And this is where some of this communication to the hospital is needing to understand where this patient's status is. This is a prior COVID patient who is recovered. There's probably little value in them actually testing that patient again. And again, now you want me to take a patient back that is COVID positive into a facility that has recovered. And so essentially it would be placing a COVID positive patient in a COVID naive now or COVID recovered facility with all the implications that has. And, we basically had to do it because it was our patient. But, many examples of where I think the test-based strategy is probably superior. Yes, I think there are cases of people who either this disease smolders, they get reinfected again, but I don't know that we can set full policy based on that. There also may be some rare exceptions where I may feel strongly about testing and someone maybe who's severely immunocompromised. I may handle that, but I may leave them in precautions forever or do something with them. If they've been on chemo, whatever their condition may be, but that's a unique case.
Mm-hmm. So we have readily available testing in the state of Washington with rapid turnaround times. And just because I had that outbreak, that second case, I had so many deaths and, I'm frankly very, very cautious, and we can get testing done fairly readily. But I have to admit, we've had a few cases that lingered on forever, and that's the one that nobody knows what to do with. And I haven't gone with a time-based strategy because I felt unsure about those these are not healthy patients, obviously. I felt unsure about immunocompromised patients. But since we're talking, so these are different strategies, and I think as long as you know what the risks and benefits are, I don't think we have any evidence not to use one versus the other necessarily. It really depends on your availability and maybe also your community prevalence. Our community prevalence continues to be very high in Washington and is climbing. So that makes me a little bit more concerned. But leads me to another question about, people, COVID recovered people. We now have our population of COVID recovered people. Most of our nursing homes are still in lockdown. And what do you do about those? How do you treat those? How do you treat them differently? That's another one, I think, where we are all sort of on shifting sand. What are we doing about that?
I think there's a difference when you talk about COVID recovered, whether asymptomatic or symptomatic. Mm-hmm. Emerging evidence that says people that are symptomatic probably got a better immune response, which makes sense. They're probably going to have IgG levels that last a while. This is ignoring those really immunocompromised people on high dose steroids, chemotherapy, and the like. But if your average old nursing home patient, I worry a little bit about the asymptomatic positives. But did they build an immune response? Are they going to get reinfected in 2 to 3 months, which some evidence states could be a possibility? Mm-hmm. The CDC really needs to do viral cultures studies.
I know.
Right. It's so frustrating that we have no idea. It's all extrapolated from younger people. Good luck.
Yeah, for example, I have a nursing home that has a current census of 65. We were much higher before. That's the same nursing home. And I think 59 have gone through COVID. So what now? Are we still, locking the nursing home down, doing all of this? And yes, we are, because that's the guidance from the state right now, and we are following that guidance. But couldn't we let up a little bit with their family visits and their community activities and so on?
You've got an NIH grant there in the making.
I think if you ask me what keeps me up at night or wakes me up at 2 o'clock in the morning with that panic and the elephant on my chest is reading some of the things that are speculating that there may not be long-term immunity.
Yeah.
That immunity could only be 2 or 3 months. I think that induces more panic in me than anything else. Because I think in my head, I have seen and I've started to write algorithms that hopefully we would get good antibody testing, even quick antibody testing. Because I think that there are so many asymptomatic. If we could really test our buildings to see who's had an antibody response, who's protected, that becomes almost a status you put in somebody's medical record. You know, just like you've had pox, you know, you're immune to the measles. We do some sort of titer and you can start to label. And I think some of our buildings where the majority have tested positive, some of those that didn't test positive were positive at some point, probably an asymptomatic, and we didn't know it. And we can almost start to switch in some of these buildings to a reverse isolation, where you allow more freedoms to the population and you're protecting you're just protecting those that are COVID naive. And that's who
we're thinking of. Mm-hmm.
So instead of isolating the positives, you're isolating those and protecting them. And I'd love to be able to get to that place. It's more the herd immunity type of scenario. But
no, you don't.
If this only lasts for if your immunity only lasts for 2 months, then, we're going to be cycling this for much longer than we ever imagined. Yeah. And I'm with Chuck, I think we need to look at, really pushing the CDC. Somebody has to start doing, we've had outbreaks now for months in the nursing homes. Somebody has to start doing these studies of looking at both measurable immunity and then looking at practical immunity. If your nursing home had some of those first outbreaks, let's do some testing in those residents and see, does it look like they get a second infection if there's, something happening in the building? We need to know this information to plan longer term.
Mm-hmm. Absolutely. Susan, any other comment on that one?
No, I think that's the issue of needing, needing good data, needing to start looking at what these strategies are, is really, really going to be key, because we don't know we kind of are making the assumption that at least immediately they're probably okay, but not knowing how long that's going to last. And we're kind of in the dark. So that's going to be really, really key as we get into concerns about resurgence, second outbreaks, and that's going to happen. It's going to happen.
So I don't know how many of you have seen second outbreaks. I have seen now second outbreaks, but those were outbreaks where like the most recent one I had is like first and second floor were affected, third floor was never affected, and now I have the outbreak on the third floor. So more like the ones that hadn't been affected, and it's like one staff member, a CNA, who came in, and we can trace it back to. It's just that's the scary part. It just takes one, and that is with PPE supposedly. And now we have 2 staff members in the hospital, one in a coma. So it's a tough situation. And we don't want to do that. We don't want to go there and have second outbreaks. That does keep me up at night as well. So let's move to our third poll. Speaking of being scared, now this is like, what are we afraid of? What scares you most about what we don't know about COVID? Persistent positives and risk of infectivity, suboptimal antibody response and possible reinfection, use of the 10-3 rule for cessation over the 2-test rule, and what PPE is really needed under which circumstances, and no data on impact of visits on COVID outbreaks. Okay, I think everybody agrees with you, Nancy.
I have that one a little.
You scared him. Yeah, so the suboptimal antibody response, and this is just what we just now discussed. Yeah. So I think that is a scary thought. I wrote the last one, no data of impact of visits on COVID outbreaks. It doesn't necessarily scare me, but it is certainly a gap that we have. And I think it's really hurting our patients because many people suffer from the long-term effects. We started, when we thought this was a short-term, isolating people, that seemed an acceptable strategy. However, as the pandemic moves on, we're now looking at the long-term consequences of that. And we are trying to, I at least, and there's a number of us trying to push to break out of that permanent lockdown, and how to do it safely. And what do we know about what the impact is of those visits, and how do you do the visits best? I would love to have some data around that, and it scares me that we don't, and so we don't promote it, and so I feel it has possible consequences. But yes, the suboptimal antibody response, and we already covered this. So, is there anything else you would like to comment on in this poll? I should have probably done that a little earlier before we commented on all of it.
Well, I will say one thing, and I think Nancy alluded to it, maybe it was Nancy before, about, the different color coding for different sections and what you're supposed to wear, and has been a little confusing with different messages. For example, in the state next to me, if you're in a quarantine unit, these staff are still supposed to be in full PPE. In my state, all they have to do is be wearing masks and gloves, essentially contact. So I'm learning what the right combination is, because, we are going to have resource issues, and, God help our landfills when this is all over, for disposables. So I think some of them are coming up with other strategies too, but, really what is the right cohorting model, and what is the right PPE to be using, I think really is key. And I think this whole issue of, we ran into issues where they wanted PUIs in a separate section from positives, and then you have your quarantine unit, and then you've got your naives. And then we also had the issue where you went through the presumptive positives who clinically seemed to have it. But they had to be separated from PUIs. And did you really want to put them in with somebody who you knew had tested positive, or, really trying to, think through what's best, and to try to figure out a simplified strategy to teach, and stop changing the rules. That was one of the nightmares in all this.
Yeah.
Nobody would make up their mind and stick to it. So,
yeah. Because we don't, the evidence is not there. But
right.
All that information that flows at us from the different agencies, I think, has been a real problem.
And it's really hard for the buildings to keep up. I mean, certainly, where you have people that can help them digest it and try to make sense of it and put it into language that they can understand. Some of them are not clinical, and even those that are clinical are nurses. I mean, to separate, this is really a whole new world for everyone. I think it's very confusing, and it's hard for them to find all of this information when it is changing all the time. To get on every listserv and read it is, and sometimes one word can make a world of difference. I think our industry, in my opinion, has really been hampered by a lack of consistent federal knowledge, and and so much has been driven more by political pushback sometimes, I think, and on a regulatory end, than really science and what's going to make a difference in the resident.
Mm-hmm. Speaking of controversy and being unsure, N95s or surgical masks? Chuck.
Well, one last comment. The only thing that keeps me awake at night is how many people die from isolation as opposed to COVID.
Well, that's what
Put a comment in there, because that's part of the equation, balancing risk and benefits of any approach you take. When it comes to N95s, first of all, it doesn't look like we can reuse them successfully. That strategy's fallen away.
So much. It's called disposable for a reason, but that's
right, right. But I think, for the vast majority, if you're not COVID positive in an aerosolized procedure, a high-risk situation, I think the surgical mask has been working very well. It's going to, again, come down to logistics. How many N95s can we afford to use? So we better use them wisely before we run out.
Mm-hmm. So some states on some health jurisdictions ask for N95 in COVID units. How do you feel about that? As opposed to only N95 in an aerosolization situation.
The unanswered question there. Yeah, the unanswered question there is how much of this COVID that builds up in the air.
Exactly, and we have some evidence that it may.
Yeah, the World Health Organization just put a little position piece saying that is a real problem, but and those are academic epidemiologists. The clinical epidemiologists don't seem to buy that as much. That with appropriate ventilation, basically just open up some windows, that's not much of a factor. If you have appropriate exhaust systems. I'm not really aware of spread of COVID with surgical masks outside of those aerosolized procedures. And there we may have to look more to the hospital. The hospital has more evidence on that. And they're using COVID when in the rooms or confined areas, but not always using COVID when they're away from a patient room. And taking the mask on and off way doesn't make sense. You're in a COVID unit, just leave the mask on your entire shift and forget about it. That's a pragmatic solution, I think.
So yeah, where I have come down, if there's a COVID unit in N95s, I think it's also psychologically probably important for the staff that we care enough. And if we have them, we use them. For everyone else, I do not, even if there is a COVID unit, I do not think that there's evidence that an N95 is needed. That's kind of how I have compromised it. Have you done it any differently?
No, the only trouble is when you have one or two people, you cohort them, you've successfully kept it at bay.
Yeah.
And nobody wants to enter the room and give care because you're blowing a mask away every time.
Yeah, yeah. That makes it hard.
It does. Makes it hard to figure out how to be efficient using your PPE.
And then we say, just keep your N95 on.
I would also agree with you, is that a lot of it for the staff, it was trying to feel that they knew that we didn't have adequate supplies for many things. I mean, you remember they were taught to don and doff very differently than we turned around and retaught them what to do. And in fact, one of our strategies is the health department came down to try to, do some education. Actually, I think it was a survey team was coming and doing education, and the videos they were showing, I go, well, that's fine, but they threw everything away and we're not supposed to do that when, they showed the videos. So, trying to reteach this. So, staff knew that we had inadequate resources. So using N95s, at least giving them that option was at least showing, I think, in a way, if we had them, that, we were trying to do something to protect them as much as we possibly could. And I don't think they blamed the facilities for that. They, like I said, just listen to the news. It wasn't the facilities' fault. The stuff just wasn't there.
And then some people bought the N95s with the exhaust valve.
Yes.
But then it's like, well, excuse me, can't do
Works.
this.
Right.
Yeah. Okay. All right. Let's go to the next poll, number 4. Now that many nursing homes settled into the slow burn phase of COVID, what is the major threat to introduction of COVID into the building? New recovering COVID admissions, new non-COVID admissions, staff not following social isolation and distancing, staff not wearing appropriate PPE while at work, and visitors when outdoor visits are allowed. We're now firmly in the category, what keeps us up at night. And Nancy, I hear you getting up at 2 o'clock in the morning. I used to be a complete, solid sleeper ever since my residency. And that has changed with COVID. We'll get into that in a minute, but that has really changed. All right, staff not following, yeah. That is what actually keeps me up at night too. So I think we all agree that new recovering COVID admissions are not a problem. New non-COVID admissions, very rarely, really. I mean, I have yet really, I've had a couple that we now mandate COVID tests within 72 hours prior to transfer to our facilities in the state of Washington. I said many nursing homes do. This is not a official mandate. And I have yet to see significant transmission. It's all staff and staff not following social isolation outside of work. And we just, from Avalon, developed a very nice poster, and I'll be happy to share it on the website. Erin, I'll send it to you. It's really heroes are always on the job, and give the do's and the don'ts and the caution, not only what we are not supposed to do. That scares me so much. And the CNA that just induced the second outbreak, I'm sure she did not wear, did not wear a mask and did not do social distancing.
We've had I say a number, I mean, I have 117 buildings. So when I say a number, I'm talking like 5 or 6 residents, which isn't many when you're spread out amongst that number of buildings. We've had some hospital admissions, even ones that have tested negative in the hospital, but then tested positive at our building. But because we're putting them on what we call an observation unit, they're in single occupancy rooms, PPE is being used with them. We've really not had them, even though then all of a sudden we retest the whole unit, we check everything. We have not had that cause a real outbreak. When we retest, we might have 1 to 2 people that are positive. We can isolate them and we're able to control it pretty well. So I don't worry so much about what's coming from the hospital as long as the buildings are well educated in handling those patients with the caution that they deserve, as you know. But I worry about what the staff are doing, and what I'm really worried about now is where are they vacationing? People have not canceled their vacations. And so, I mean, and from my regional staff to my nursing staff to everyone, if I hear of one more person saying that they're going to Myrtle Beach for vacation, and
that's not funny.
Our states have, the state has said that if you travel to other states, it's a mandatory 14-day quarantine. So then that allows us to mandate that for our staff. But there's ways they get around it. I mean, they don't tell you where they're going. I mean, they don't, all of that kind of piece. But that's what I'm seeing and even worried about, more so than just that one aide who might go to a bar. Some of our staff work so many hours, I don't think they have time to go to bars. But they go on vacation, and that seems to be a problem. So, I'm like, the staycation, let's just stay here.
Save the money.
Exactly.
Save your money. That's right. Yeah. I worry about those bars, though. I do, although that's shut down now. I worry about the politicization of face masks. I worry about people thinking that it's warm outside, it's over. Although I think people have gotten hold of the facts now. I mean, now that we've had other spikes, that this is actually not the case, that we are still in it, and we are in it fully and never so much as before. So, but that is a huge risk for our patients. And how do you, so we have this poster, and the poster, the messaging, the tracing, and the publication of, oh, this is how it happened. What other strategies are you employing in your facilities? What do you know? Just one word, staycation?
Yeah. It's built our hospital association, actually in the state, does follow the Google Mobility Index of Missourians and post that along with hospitalization. Google knows where you are on your
Mhm.
phones.
Mhm.
And so you can correlate that. You can see ahead of time when we've had little mini spikes in the population, people are more mobile.
Yeah.
I pointed that out to our staff in the nurse homes that, you know, there's proof that the more you move around, the more we're going to see COVID.
Right.
But teaching that lesson is very, very difficult. And then family events come up, a major birth, a death, something. It's hard to tell people not to.
Right. Right.
Well, I think the strategy I've employed is to tell people what to do. Don't tell them what not to do. I mean, do tell them, but tell them what else to do, what else could be fun. So that was one of my hopes. But Dr. Saman just says here, one of my facility had terrible outbreak after 2 CNIs decided to go to the next town and party. And that's something that we have to be relentless about. You know, you are on the job, you are responsible, you are at risk. I think we just have to be relentless about it, and at the same time really supportive to the staff, I think. All right, let's
I would say too is, I mean, if it's going to keep me up at night, is I do not think we're out of the woods yet for PPE. You know, I mean, we're larger, and so I think that they, you know, we've been able to source more masks, and we went through a period that's been really pretty easy. But I think as cases go up, you're going to see mandatory masking in communities, higher hospital rates, their burn rate of PPE is going to go up. We're going to see that shrink, and I think you could see shortages in areas we haven't seen shortages before, even things like gloves, which is scary because that's part of universal precaution for other illnesses that are even scarier than COVID. So, you know, just because we got over that first hump, all this stuff that's been our nightmare is going to come back. I don't want to be a downer, but we have to
be my nightmares, but yeah, I know what you mean.
So it's a good time to do those studies.
Prepare.
You know, is a surgical mask enough? And now that we've talked so much about the N95s to our staff, I think they want that. And they think that is the best, it's the gold standard. So it will take a whole nother campaign if we say surgical masks are enough,
right,
to convince them of that.
Yeah, and data is always our friend, isn't it? So we're gonna, so thank you so much. We're gonna close out with one poll, and Erin, put on the last poll. In the last 4 months, how many days have you taken off work, including 4th of July?
This is weekdays, right?
Oh, weekdays.
Weekdays.
Well, we did go to, okay, so we did that, so.
I actually submitted something this time. Oh boy. Oh boy. Yes, I think I have to be worried about all of us, and really remember that this is a marathon at this point, and not a sprint. And even if you can take off, make sure you practice good self-care. And remember that we are all in it for the long run. I want to thank everyone for participating in this important discussion, and maybe that poll will be another AMDA Grand Rounds. We all learned much. Some pearls, I think, is prepare, prepare, prepare. Knock, knock, knock on, and keep that up, those government connections. Let's be relentless. Let's be annoying if we need to. be very prepared for the flu season and use that opportunity maybe to get into mandatory vaccination. We talked about cohorting. We talked about are we going to continue to do that, and we have pretty much outlined needs that we still have as far as research, such as how long, what is the test-based versus the time-based strategy, what's the outcome of that, and what about viral cultures and so on. So hopefully those data will be available to us soon. And thank you for sharing your insight. I think that was really valuable to all of us, including myself. I really, once again, learned so much. And thank you for sharing your expertise with us today. AMDA will continue COVID Grand Rounds as a peer-to-peer discussion and bringing you topics of the greatest interest to you. But here too, we are now realizing we are not in a sprint, we are in a marathon, and we're going to lengthen the time in between the Grand Rounds to every other week as opposed to every week. So we'll move forward with that time frame. And we will see you all again in 2 weeks. Be well, and thank you for all you do. Bye-bye.
Bye.
Bye. Thank you.
Sabine.
Thank you.
Done a great job.
Thank you.